Good day, colleagues, and welcome to today's session. My name is Francis Ochen from the African Society for Laboratory Medicine. I'll be your moderator for today's session. Today, we are focusing on advanced HIV disease management. As you are aware, we have been with HIV for the last about four decades, 40 years or thereabout. And because of the advancement and the kind of the growth of programs, we have seen marked improvement in really the prognosis of the disease, but also the diagnostic tools that are applied. But we are also aware that even with all these advancements, we still see people coming late and coming with advanced HIV disease. And so today, in the first of about 3 series of our sessions that will be running on advanced HIV disease management, we will be walking us through some of the guidelines and then some of the tools that are applicable, but also some of the basis for the guidelines and the tools that we are speaking to. And we'll be focusing really on repositioning CD4 testing as one of the key criteria in HIV advanced disease management. And to take us through this, we have 2 distinguished speakers. Our first speaker is going to be Professor Kamo Alani Sulaimon. And Professor Sulaimon is from the College of Medicine at the University of Lagos in Nigeria. He will provide the first presentation, and thereafter we will hear from Eman Alesik. And Eman is a global product manager with Akubio. And colleagues, without taking much time, given the amount of info that we are going to be covering, allow me to hand it over to Professor Alani to take us through the first presentation, and then we'll move to the second presenter. Again, remember that your only way to contribute and engage in this discussion is through the Q&A space, and kindly post your questions or comments therein. Professor Alani, let me hand it over to you.
Thank you very much, our moderator. The topic we are examining today is establishing CD4 testing as a clinical priority in the setting of advanced HIV disease. And what we're actually talking about, first of all, is to look at the CD4 molecule as the major contributor to the immunosuppressive illnesses that an individual that is HIV infected has as the major problem, underlying problem. Once the CD4 molecule bearing cells are not there, you run into trouble. We want to look at how important CD4 molecule is to the health of an individual who is HIV infected. And we want to see how CD4 molecule enumeration over the years has actually shaped the criteria for indications of antiretroviral therapy, and what happened that at a point in time, we decided that we really do not need the enumeration of CD4 cell count for us to start an individual on antiretroviral therapy. And what happened again? They were now coming back to say it is now important that we cannot throw away the CD4 cell count testing as an important contributor to quality of care in HIV space. And we're going to see actually what happened in the next 2014, 2015 up to 2017, when we started to see this CD4 cell count. We thought it was not very necessary, but now is the decider between those who will live when they initiate ART and those who will die as a result of initiating ART. So at the end of the day, we will discuss what are the reasons why we are talking about bring back CD4 cell count enumeration, because it's a tool, it's an important laboratory investigation that helps us to decide who lives and who dies when he or she needs to take antiretroviral therapy. Now, talking about immunopathogenesis of HIV, we know there are 2 major disease conditions associated with HIV infection. The very first one is what we call viremic illness, which is occasioned by the so-called cytokine storm. The cytokine storm is a situation that you do not need to have low CD4 cell count before you suffer from disease associated with cytokine storm. What is happening is the presence of the virus in the human cell, and the human cell is responding to the presence of the virus by elaborating what we call is a reaction to the presence of the cell. If terminology comes back before I finish, I will tell you. But once a cell is infected by a virus, you begin to elaborate these cytokines. And these cytokines are such that they reset the thermoregulatory center in the hypothalamus, particularly the so-called tumor necrosis factor. There are a number of other cytokines that are produced here: interleukin 1, interleukin 3, interleukin 6, including gamma interferon. These are the responses of the cell to the presence of the virus in their cytoplasm. And these are the things that actually happen that we refer to as the cytokine storm that causes the illnesses, which we refer to as the acute HIV infection illnesses. These illnesses may look like flu-like illnesses. The reset of the hypothalamic temperature regulatory center to somewhere around 38 degrees centigrade makes the individual to have feverish feelings, low-grade fever throughout, and is associated with continuous loss of weight because of loss of body water, to ensure that the amount of water that is heated by that 1 degree centigrade in body temperature is completely left the human body, so that the human body does not get completely burnt off. We have said that 1 degree rise in body temperature, the amount of energy that actually causes that is enough to burn down the tissue of the body if there's no water in the human body to absorb that amount of heat that raises the body temperature from 37 to 38. And you see an individual with infection, HIV infection in the first 2-3 weeks or 4 weeks of exposure to the virus, presenting which we call cytokine storm mediated illnesses. And it's not different from illnesses that somebody that has malaria will have, including fever, fatigue, myalgia, night shift. This is what you have. And except you have a high index of suspicion, you are not even going to suspect that what is happening here is acute HIV infection. However, I want to talk about diseases of immunosuppression, because that is where the individual become severely immunocompromised, and they now have what they call opportunistic illnesses that gives the disease that we call it a form or a shape. What is happening here is that the cell that is infected in the human body, the cell that HIV infect, they are type of T lymphocytes that carries CD4 molecule on their membrane. And we know that there are at least 5 types of T lymphocytes. One of those 5 types, what we call the T helper cell, is those cells that bear the CD4 molecule. The other types that you have the CD8 cytotoxic T cell, T delayed hypersensitivity cell, T suppressor cell, as well as T natural killer cells. All these cells, for them to have normal function for the human body, they require what you call helper signals from the T helper cells. The cytotoxic T cell, for example, is the God-given cell against viral infection. Any cells of the human body that is virally infected needs to be eliminated by cytotoxic T cell. But that is not going to happen if T helper cell is not there, giving helper signal to it. The T delayed hypersensitivity cells, these are the T cells that you see in the area where you call granuloma. They are a cell that supplies something like gamma interferon that helps the monocyte in the granuloma to be able to digest chronic bacterial infections. And you don't have support from T helper cells, you will never be able to handle chronic bacteria, particularly the TB organism. The T suppressor cells is the cell that help us to limit what we call immune hyperactivity, so that if an individual is a tendency of producing unnecessary antibody that is going to lead into immune complex disease, you have T suppressor cell that is going to check it down. And of course, you cannot be able to do that if the T helper signals is not coming. The T natural killer cells, this is the cell that God Almighty has given to be for us to be able to identify any human cell that appears to be undergoing mitotic change or a malignant change. And that change signature on the membrane of the cell is supposed to be identified by T natural killer cell. T natural killer cell function is also not there if T helper signal is not coming from the T helper cell. It is not only the T cell functions in immunity that T helper cell actually affect. The monocytes are equally affected. The B cells are, in fact, the B cells is incapable of producing antibody if the T helper cell does not give signals to support it. It's for me, and that is why you see majority of patients with living with HIV infections have varieties of acute bacterial illnesses. So we understand today the mechanism of CD4 T cell lymphocytopenia, but we know we do not have a mechanism or what you can use as an armamentarium to block the mechanism by which HIV infection is causing CD4 lymphocytopenia. What is important is that do not allow HIV to come in, and if you allow it to come in, you must be able to stop its reproduction. If you don't stop its reproduction or its replication, definitely you are going to have CD4 T cell lymphocytopenia, and it's a major cause of immunosuppressed conditions that characterizes what we call AIDS. Now, what CD4 T cell count enumeration has helped us to do in the setting of HIV infection is that we have used it over the years to take a decision who is qualified to start ARV, who is not qualified to start ARV. In the 1990s, for example, you cannot start antiviral therapy until your CD4 cell count has dropped down to as low as 200 cells per millimeter cube. But that has to change over a period of time. And the reason why that was so as at that time was that what we call ARV or antiviral therapy drugs that we have are highly toxic drugs. We're talking about something like nevirapine, something like citabine, cytofudine. Many of these drugs are so toxic. And if immunity was very robust, at the time you are initiating it, it actually causes very severe transaminitis, and people actually die. So they will say, weigh the reasons why you want to start antiviral therapy. You must allow the immunity to be weakened, and it's like as the stronger the immunity, the stronger is the capacity of the individual not to be able to resist what they call immune inflammatory syndrome that kill individuals at that time. So you will wait until the viral load, so until the CD4 cell count is quite low. But in the 2010s, in the year 2002 up to year 2010, a number of antiviral therapy have come into the space, and we are able to have more tolerable antiviral agents that do not stimulate transaminitis and severe reactions in the human body, and we are able now to initiate antiviral therapy at a higher CD4 cell count. That is the time they say, okay, you can initiate antiviral therapy between anybody that has 200 and up to 350. And of course, in the 2011, 2012, 2013, we were able to show, have an evidence, in fact, that the higher the CD4 cell count of an individual, so at the time you are initiating therapy, the more likely is it going to survive, and that morbidity is a lot reduced. That is why you will see in the 2013 WHO guidelines, they tell you, initiate ART in all individuals, regardless of CD4 cell count, if they have severe or advanced HIV disease. Or you can initiate ART if CD4 cell count is less than or equal to 500 cells. So up to 2013, we were still working with determining the baseline CD4 cell count before you initiate antiretroviral therapy. What happened in 2014, in 2015, we now have these two big studies, the INSIGHT study and the Tempano study that were published in the New England Journal of Medicine, the two of them in the year 2015, that gave the evidence that the earlier you detect an individual with HIV infection and you start antiretroviral therapy, the better is the survivor and the quality of life that this individual will have. At that point in time, these two different publications canvas that we really do not need to wait for CD4 second. In fact, we don't even need to know CD4 second. Just smell, taste HIV. Once it is there, just start antiretroviral therapy. And the response to that in 2015, that same 2015, we have this rapid advice from the WHO that stated that ART should be initiated in all adults living with HIV at any CD4 cell count. And at a point in time, he said, you don't even need to test for CD4 cell count, just test HIV antibody positive and start antiretroviral therapy. And it was also argued that once you have tested the individual and it's positive, the money you should have devolved to doing CD4 cell count, please add it to the money for you to assay viral load so that more people can actually access a viral load, because that is more definitive indicator of efficacy of therapy. And we all believe that in 2013, 2014, 2015, until we begin to see something else that was happening in 2016 and 2017, when we now saw that large number of people have accessed antiretroviral therapy, and that the observed AIDS-related death that was declining by 2014, 2015 plateaued. We no longer see a continued decline in AIDS-related death. People are now taking more tolerable, more effective antiretroviral therapy, and they are getting the so-called goal of antiretroviral therapy, which is virological suppression. But at the same time, in the public space, the AIDS-related death is not declining. What was happening? What was happening was the fact that the large number of people that were initiating antiretroviral therapy anew were dying 2 to 3 months after they initiated therapy. Those who have been stable on therapy were not dying. What is making the people who are detected initiating therapy up to 30 to 40% of the people who are getting on the therapy were dying? What was the cause of that? The simple reason of that was that we now find out that up to 30-40% of our dying had what has been now termed advanced HIV disease. And the evidence is there, even in the Nigerian data, where you see the uptake of the scale up of ART in Nigeria. You can see the scale up, and of course, the decline by 2014 in the AIDS-related death has plateaued. We are not seeing a decline in AIDS-related death again. So as soon as we are starting ART, we are also dying 2 to 3 months after that. What was happening is that up to 30-40% of those that were initiating antiretroviral therapy had advanced HIV disease. And what is the so-called advanced HIV disease? Is a situation where you started antiretroviral therapy and the antiretroviral therapy appears to be very effective. You have a rapid decline in the viral load and rapid immunological response to your therapy, and you now generate a lot of very active CD4 cell or T helper cells that needs in your system what we call heavy antigen load. Because when you are immunologically suppressed, you have what we call a high antigen load. You have TB that is not manifesting. You have meningitis that is not manifesting. You have pneumocystis that is not manifesting. All these diseases are there, but they are not manifesting because you need immune cells for them to express as inflammatory cells that will give you the symptoms. The moment you start antiretroviral therapy, that is very effective, and the viral load sharply comes down, and immune response comes up and the TB antigens are there, protocol antigens are there, and you now have generated immune cells that can identify them and set up inflammation, then you come up with the diseases. This is why many people come with immune reconstituent inflammatory syndrome and they are dying. So there are 5 major diseases that we know were killing people who initiated antiviral therapy at very low CD4 cell count using very effective, very potent antiviral drug. The TB, cryptococcal meningitis, toxoplasmosis, the PCP, as well as bacterial sepsis. These were the causes of death. So we know that at the time that we were saying test and treat, just the HIV positive and start treatment. That was the time that we also introduced DTG as an important component of first-line therapy. DTG happens to be a very, very potent antiviral drug that sinks viral load very deeply, and of course, there's a robust immune response. Everyone that have very low CD4 cell count and is initiating DTG as component of first-line therapy will have high risk and are likely to die. And this is why it is now said by WHO, look, we want to find out who is going to die when we initiate potent antiviral therapy and who is going to live when we are going to initiate antiviral therapy. What we have found out is that those that are dying are severely immunocompromised. We have brought back the CD4 cell count. You must have CD4 cell count. And once CD4 cell count appears to be low, you will not initiate antiviral therapy. You will initiate what is called advanced HIV disease package of care, because you want to treat a disease that is going to kill you first, so that when you initiate antiviral therapy, those organisms, antigens that is going to set up and going to take inflammatory reaction that is going to kill you have been taken care of. This is why WHO say there are 4 package of care that we call AHD package of care, the diagnostic package. And that diagnostic package, top on the list of diagnostic package, is what is the baseline CD4 cell count. The other diagnostic package, you want to test for presence of TB, you want to test for presence of toxo, you want to test for presence of CP, and you want to see, particularly in children, whether they will have bacterial pneumonia or not. That's the package of care that came up as far back as 2017, when it was known that from 2014 to 2016, you start antiviral therapy, you have 30 to 40% chances of dying if you do not know that you have severe immunosuppression. So today, we are saying CD4 cell count that we thought was no longer necessary because we don't need it to monitor efficacy of therapy, because we don't need it to initiate antiviral therapy, has to come back because we know we need it to be able to decide who lives, who dies when we initiate antiviral therapy. And I'm also saying to us, you also need CD4 cell count to be done if you are going to continue to carry out research in the field of HIV/AIDS, because you want to talk about death outcomes and there are no relationship with CD4 cell count. I don't think it's a good paper. I, as a reviewer, will not take it from you. You want to look at attrition. Those who are living therapy and maybe they went to die or they change, what is their CD4? Does it predict attrition that you see? And what are the susceptibility to different opportunistic infections? If you are still doing the study in HIV medicine, these are still things that we must continue to do. So you cannot say you don't need CD4 cell count any longer. So in summary, what I've just been able to tell you in the last 20 minutes are the following. Number one, we have said that CD4 cell count is no longer required for initiating treatment. That is true. You don't need it. Everybody that is HIV positive will need it. However, you must remember that the T helper cell, or the CD4 positive T cell, is the cell that is infected and killed predominantly by HIV. An individual who do not have quantitative immune recovery, an individual who do not have what we call pathogen-specific immune recovery, you will want to know what CD4 cell count are in this individual. Don't ask me what is quantitative immune recovery, pathogen-specific immune recovery. If you have time, I can dwell more on that. In 2017, WHO also told us, yes, we agree, viral load is the way to go to monitor efficacy of antiviral therapy, but for individuals who are still immunocompromised, who have not achieved biological suppression, you still need to monitor the CD4 cell count in this individual every 6 months until patients are stable on ART, and there's a definition of stability on ART that you have to meet before you will say you don't need to know what CD4 cell count individual is. You need to have the CD4 cell count to initiate or to stop prophylaxis for opportunistic infection. Because there's somebody is severely immunocompromised, you have started an opportunistic, you have started prophylaxis. At what level of immune recovery do you want to stop this opportunistic infection prophylaxis? You need to know the CD4 cell count. And there's no way today you will manage advanced HIV disease if you do not have at least baseline CD4 cell count. And we must continue to monitor patients who are returning to care after initial default. We want to know how bad is the level of immunity, because you may have to start them on advanced HIV disease package of care. And those who are also failing therapy while on care, you want to know what is happening to the CD4 cell count, because you really need to prove that whether they will need some form of prophylaxis or the other. So CD4 cell count is still out there. And today, in the era of BTG or any other highly potent integrase inhibitor like bictegravir and a number of other integrase inhibitor, and you do not want to know the patient's CD4 cell count and monitor the response of individual to CD4 cell count, it's going to be a bad practice and a poor quality of service to your patient. HIV/AIDS research means that when we are measuring viral load, we also want to know the level of immunity. And I want to stop here. I thank you for your attention.
Excellent story there from Professor Alani. Allow me use that easier name for me. What an excellent walk through the immunology of generally viruses, but specifically speaking to HIV. Also an impressive cover of the progress we've had with the treatment guidelines related to HIV care and treatment. And of course, getting to the immune reconstitution syndrome and whether treatment in newly identified individuals should be initiated right away, or should it be delayed so that we can allow the body to recover and not recover so rapidly to the extent that the body can begin destroying itself, given the antigen load, did you say, the high antigen load that would have been accumulated over the time that somebody was going down with the disease without a treatment. Excellent presentation from Professor Lani there. And we will now move it to Eman, and Eman will take us through one of the tools that is currently in use. But allow me remind participants that this excellent presentation is brought to you given the funding support from the Bill and from the Gates Foundation. But also, please join the discussion through the Q&A space. Please get us your questions and comments coming through the Q&A space. Eman, let me hand it over to you for the next 10 minutes, and then we'll get back with the questions.
Okay, thank you. Thank you so much. Yes, great presentation by Alani. So I just wanted to take you through a little bit of a story about our Visitech CD4 Advanced Disease product. So thank you for being here today. So first we will begin by explaining why CD4 is the gateway test for identifying AHD in people living with HIV. As we know, CD4 T cell counting is a pivotal indicator of this. And if you can have a look at this graph that's on your screen, you can see that the level of CD4 count will gradually decrease over the weeks to years of a person living with HIV. Okay, so what we see over the course of that infection, as we end up in the the stage where the CD4 count heads to around 200 cells per microliter, we call this advanced HIV. As we heard from the previous speaker, we know that advanced HIV disease is really present in a lot of patients that are attending at their first visit. This is estimated at 1 in 3, but latest estimates are sitting around 40 to 45%. So this is actually increasing over time, unfortunately. And we know when we've got an opportunistic infection screening that follows AHD case finding, we can see that these patients living with HIV can be co-infected. So they would be infected with histoplasmosis, tuberculosis, cryptococcal meningitis, just to name a few. And this is a really important feature of the importance of testing for CD4 and then being able to categorize those patients as high risk. With our Visitech CD4 Advanced Disease product, it is a unique same-day CD4 test. It is a lateral flow device, point-of-care testing, where we can take it to where it's needed most, specifically in decentralized settings, where you can test it anywhere and anytime. It's CE marked, it has WHO pre-qualification, it's a visually read test, therefore no instruments are required. It's affordable. So when we talk about the conventional CD4 test that's in the market currently, we talk about flow cytometry. This is an expensive with long turnaround time processes, and there's been a lot of issues with reagent supply and instrument servicing in the past few years. In addition to that, many of the flow cytometry tests on the market are being discontinued or taken off the market. So this is the really important point to understand. When we think about where we're testing, I think it's really important to look at the health system and the levels of care in the health system. So we can see that above this dotted line, we have regional centers, laboratory reference centers, and this is where the testing capabilities are quite high. You have high volume testing, you have access to those health specialists in those regions. But when you talk about below this dotted line, it's really important to focus on the primary care and the district hospital levels where the testing capabilities are limited or non-existent, and there's a really high risk to loss to care for patients. So some key benefits of Visitech CD4 Advanced Disease is the following. We can see that it can accelerate clinical management. What that means is clinicians can make quicker decisions and expedite looking for opportunistic infections in patients living with HIV. Next, we look at reducing the loss to follow-up. We really need faster turnaround times. We need to make sure patients are retained in care. We need to reduce costs. Visitech CD4 as a lateral flow device is cheaper than flow cytometry. There are no costs for equipment. There's no cost for sample transport. And we can use this test to test anywhere anytime. We always joke and say that you could do this under a tree. You don't need to be in a laboratory setting. And I think the key thing here is that it's designed for the use at point of need and it's visually read. And lastly, we improve the patient outcome. We have more rapid interventions and that can reduce morbidity and mortality, which is our most important point there. So let's take a look at the patient pathway in decentralized settings. First, I'll focus on the flow cytometry pathway. We talk about patients presenting for care as normal, but then we have the following steps. Venous blood sample is taken, the sample is taken to the laboratory for testing, the patient then has to wait 1 to 2 weeks for laboratory testing, the patient then has to return to the facility, and then clinical management can ensue. But what are the negatives associated with that? And let's touch on those. We have a lot of costs associated with transport. We have expensive laboratory equipment and reagents, and we have an utmost risk of loss to follow-up because the patient then has to take another day off their work from their families to re-attend the clinic. And therefore, there's a risk of poor outcomes because the clinical management might be delayed. When we look at the pathway and how that can be changed with the addition of Visitech CD4 in decentralized settings, we see the patient presenting for care as normal. But then we can take a venous or finger stick sample from that patient at that time. We can test the sample immediately while the patient is waiting, and then we have clinical management on the same day. So where have we, recovered, our costs and time? So here we can see there is no sample transport. It's an inexpensive test, and you can do this in terms of, like, we can see immediately a reduction in cost. We have the loss for follow-up for the patient. As I mentioned before, the patient doesn't need to return. And then lastly, we improve the patient outcome because they can be treated in that same day. So taking a look at some of our milestones, we achieved CE marking in 2019, we were pre-qualified in 2020, and we've now been adopted in over 50 countries. We've expanded our training of Visitech CD4 across 5,000 plus trainees, and this includes trainer of trainers as well as end users, and we've sold over 3 million tests. We've had a significant number of funder and stakeholder support over the years, and this is just to highlight some of those on this slide. So let's take a closer look at how the test works. So this slide is focused on when we take our sample. So first we have to decide, are we going to take a finger stick or a venous EDTA blood sample? We look at, we're taking 30 microliters of blood, 30 microliters of whole blood. We then wait 3 minutes after the blood addition to the device, and then we add a drop of buffer to well A. Following this, we need to wait a further 17 minutes, and then we add 3 drops of the same buffer that comes in the kit to well B. We wait 20 minutes, and then we have 5 minutes to read our result. So let's take a look at how we do read those results. I'm going to ask you to focus on this center image here. What we're looking at here is the control line, which is always present to present that it's a valid test. We then have a 200 reference line and a T line, which represents the patient's result. When we look at this image, we can see that the test line in this middle image is darker than the reference line, and therefore the CD4 count is above 200 cells per microliter. When we look at the images on the far left here, this is examples of what you might see when the result is below 200 cells per microliter. So visually you can see when we look and focus on the area of the 200 reference line and the test line, in the first image, the test line and the 200 line appear in equal intensity. On the second image, you can see that it's lighter, and on the last, it is missing. And so what we can see here is below reference or below 200 results. So lastly, these images just represent what you would see if the test was invalid. Okay, so in terms of clinical performance, on the top, we can see that this is the clinical performance results that you would see in our product insert. We have finger stick and venous results looking at sensitivity and specificity. There's no significant difference between neither method of sampling, and you can see that there is sensitivity above 86% and specificity above 92%. Below that, you can see some results from an independent WHO pre-qualification performance evaluation study that was conducted in Kenya. You can see again, no significant difference between the results between finger stick and venous testing, and the sensitivity is above 95% and specificity above 96%. Further to this, of course, as I mentioned, we've trained over 5,000 people on how to perform Visitech CD4. And in addition to that, we've developed our own AccuBio Global Learning Center. The GLC is a unique learning platform that provides training on our product. It's a free 1-hour course. You can use it anywhere, anytime, using your laptop or mobile device, and you can obtain a certificate that you can download afterwards. You can access it many times as well. So it's really great because it's available in multiple languages, including French and Portuguese, as well as English. And we have, in addition to the Global Learning Center, many support materials and training materials. So they are in multiple languages, and we also have technical guidance and troubleshooting documents. And further to those materials that we've developed, we're now working with organizations like ASLM, who we're presenting with today, to expand coverage of these materials to support training in sub-Saharan Africa. So the Scale Up is being conducted with, in conjunction with ministries of health in various countries. Our first rollout of this program covered 11 countries, and phase 1 trained over 230 trainers. The phase further plans to step down to train healthcare workers at facilities, and this is underway currently. Thus far, training has expanded to a further 475 end users and plan to expand. We've learned that early stakeholder engagement with ministries of health and key partners is critical to accelerate scale-up for advanced HIV disease testing. And in the future, we plan to further cascade trainings and request further funding to cover another 12 countries. Furthermore, I'm pleased to announce that we now have access to an external quality assurance panel system for VisitX CD4. This has been developed by a company named SmartSpotQ. They're based in South Africa to develop EQA and verification panels. This was piloted early last year in Nigeria, Zimbabwe, and Lesotho, and now is available for participation. This consists of 3 panels per year with 4 samples per panel, with the first panel being available for April of this year. This plans to assess test accuracy, result interpretation, training effectiveness, user proficiency, and adherence to test procedures. And if you're interested, you can scan the QR code or follow the links on the slide. So lastly, I just wanted to present that we have a wide range of products in our product range at AccuBio. In addition to those shown on the slide, AccuBio have recently launched metabolism lateral flow range, a comprehensive fluorescence immunoassays test menu, which spans a number of clinical areas, and our biochemistry and chemiluminescence immunoassay rapid benchtop systems for decentralized testing. So I just wanted to leave it there and thank you for your time. And lastly, I'm just going to show a couple of testimonials that are from 2 of our organizations that are based in Nigeria that are going to just talk a little bit about their experience using VisitX CD4. So the first presentation is a presentation by Ojadi Victor Okunwili, who's from the AHF Foundation for AIDS Healthcare. So let me just play that.
Hi everyone, my name is Victor Ojadi. I am a medical laboratory scientist. I'm glad to share with you today my experience over the years using VisitX CD4 test kit. It is a test kit that uses lateral flow immunoassay techniques. It provides visual, semi-quantitative results in 40 minutes. It has a lot of advantages. It doesn't require electricity. It's instrument-free test kit. No computer. It is easy to use. It is majorly designed to screen advanced HIV disease. In fact, it requires minimal training. At all our facilities where we don't have laboratory personnel, I train non-laboratory staff, nurses, and community healthcare workers, and they are doing it fine. They have been doing it. In fact, the test kit has helped us to achieve 100% coverage in all our facilities, because it doesn't require electricity. You can do it in the rural area, in primary health care, all the facilities. We have been using it, and it helps us a lot. Some of the advantages is that you can run multiple samples at a time, provided you have your timer. When you compare it to other CD4 testing platform, you can see that VisitX, in fact, is a game changer. It brings all the gap, all the challenges in the past surrounding CD4 testing. VisitX has addressed it all. It is very good, and we have been using it and we continue to use it because it saves time. clinician will be able to make the decisions within 1 hour, because the result, it takes 40 minutes for a result to be available. It has reduced loss to follow-up across all our facility, because the patient don't have to go and come back the next day. It's a very good.
So just in the interest of time, we'll pause the slide and I'll hand over to Francis.
Thank you very much, Eman, and again, another very great presentation on one of the many possibly products out there that we can use to, in a dichotomous way, tell people who are below 200 and those that are above 200 in ascertaining the advanced HIV disease status. And in the interest of time, I'm not going to do a lot of summary on this. Let's kindly run to the questions and keep the questions coming. We will deal with all that we can deal with, and then those that we cannot, we will make them available to our presenters and they will form part of the package that will come to you. Now, let's start with a question that comes in from, the names are, in no particular order. There is a question, and let me start with you, Eman, on the performance of the devices, and you and Kofo should also be able to jump in here. I have two questions that are related to the performance. The first is on the issues around passing verification on site. I think there is a question from Namudu that says that they've had issues with the strips not passing verification at their facility. And so could this be a function of the training or the procedures or the interpretation? I have gone through the training myself, and sometimes we think this is a simple device and anyone can use it, but I'm telling you it is very, very technical. Do you want to take that question on the performance of the device and also some of the issues that might be related to the failed verifications?
When you're talking about failed verifications, do you just mean in comparison to the performance of the flow cytometer at their sites, or their verification of using it in their hands? Just to clarify.
That is not in the question, and you can generally just speak to it. Yeah.
Okay. Okay, fine. So in general, what we always say is that it's important to run a number of samples, obviously with, known CD4 counts, if it's possible, in your facilities while you're integrating Visitect into your services. Because of course, with any test, even though Visitect CD4 is a lateral flow and it's a rapid test, and in your mind it might seem that it's a simple test to use, it's a lot of complexity inside that's working. So we just need to ensure that you have a full understanding on that, as well as how to read the result. This is probably one of the key things that we found in the field that people have issues with. It's that result interpretation. So we really recommend that you have a lot of test experience, and you can obviously access our Global Learning Center. One thing I didn't mention with our Global Learning Center is that you have access to over 45 images that you can repeat, visually reading the test result, and that really helps people to understand that part.
Excellent. And let me just keep it with you before I get to Prof. Alani. There is also a related question on the use of the device, but from the angle of self-use. And so somebody is asking, I think I didn't get the name, and is asking if the test device can be recommended for self-use. And so if I am the client, am I allowed to use it at home on myself? And then what decision do I take if I am to use it as a self-administered device? But that's a question for you, Eman.
Yeah, I mean, at the moment, we're not in that way. It is a professional use only test. It's not a self-test. So you would need to have a healthcare worker perform that. So that would be my response.
Great. Thank you. And now let me move to Professor Alani. And again, thank you both for a very great presentation today. Now, there is a question related to the survival after treatment initiation. And this is an anonymous attendee who is asking whether, I think there was a mix-up, but I think you must have clarified it later in the presentation because the question came early. There was the thinking that the non-survival of those who initiate treatment early was due to drug toxicity, other than immune reconstitution syndrome. But just for your clarity, the people who were dying within 3 months of treatment initiation, what was causing this? And very briefly, because I know that probably you answered this question towards the end of your presentation. Professor Lani, did you get me? If you're speaking, you're on mute.
Sorry, I didn't know that I was on mute. I was muted. So I was actually trying to answer this online. The truth of the matter is that the drug we are using today are very tolerable drug with little or no side effect. What is killing the individual 2 to 3 months after initiating treatment today is what we call high risk. And the group of people that will die are those that have severe immunosuppression as at the time they are being diagnosed. So it is actually the response to the therapy that is killing. It is not the toxicity. In the past, toxicity of regimen was a major issue. Hepatic, inflammation, transaminitis, very severe, toxic side effects were killing. Today, what would kill an individual with HIV infection is robust response, immunological response to the antiviral therapy. This is why we say you must not start antiviral therapy if your immunity is very low. That's why we say today, we must know the CD4 cell count of everybody that is testing HIV antibody positive and new. The reason being simple. We now know that up to 30 to 40% of people who are testing positive today still have very low CD4 cell count. Only about 60% of them will have CD4 cell count below 200. The truth of the matter is that if your CD4 cell count is low, Mr. Facilitator helped me to clarify it later, that you have a high antigen load, infectious load, that you are not showing any symptoms for because you don't have inflammatory cell that will set up the inflammation. Or you see your immunity is very low. But the moment you receive very effective antiviral therapy, the viral load crashes. And then your immunity comes up. And then infectious diseases are still there. So you now have immune cell that will set up inflammation against those infectious diseases. So you can now have what you call TB iris, TB meningitis, TB toxoplasmosis, iris toxoplasmosis. So it's whatever is the infectious aid that you have at the time that your immunity wake up that is going to be the killer disease. And we don't recognize it on time. You see viral load shutting down, you see the CD4 cell going up, you think the individual is well, individual is not well, because you are just giving that individual inflammatory cell that will set up inflammation that is going to kill that individual. It is not the toxicity of the drug, it's the response of the individual to the drug, or immune response of the individual to the drug. We didn't consider it as toxicity. Over.
Great, thank you very much, Professor Lani. And let me keep it with you. Rodrigo, I've seen your comments and they've been consistent. We will get to that at some point. But let me keep it with you, Professor Lani, on the access to other advanced HIV disease packages. And I know that, like I stated when we were starting, this is one in a series of many sessions that we're going to run with regard to our advanced disease, advanced HIV disease management. But Claire is asking the access to other packages that goes with advanced HIV disease. Do you have some experience to share in terms of access to CRAG testing, access to TB LAM, and other packages that go with advanced HIV disease? How is it playing out in the space that you are such an expert in?
As I earlier said, there are 5 major diseases, although there's a 6th one, that is histoplasmosis. I was actually responding to that one too. There are 5 major killer diseases in an individual that has been labeled with diagnosis of advanced HIV disease. Top on the list is TB. Second on the list is cryptococcal meningitis. Third on the list is cerebral toxoplasmosis. Fourth on the list is pneumocystis jirovecii pneumonia. And the last on the list is bacterial sepsis. Now, the TB is the major cause of death in about 35% of people that are going to die as a result of advanced HIV disease. And next to it is about 20% coming from cryptococcal meningitis. And these are the 2 major diseases that are programmed for. You will see that in the WHO treatment guidelines, which is copied by most national guidelines, you will see that we program to manage, to give the package of care to manage TB, package of care to manage cryptococcal meningitis. And part of the management is diagnostic package. Diagnose those 2 diseases. Diagnose TB using TB LF-LAM, diagnose TB meningitis using the CRAG. And those bacteria or commodities are provided for routinely in most national programs. When they are not there, please ask your national programs, because this is what you have agreed to in most national program treatment guidelines. Although we have a stock out from time to time, it is important that if somebody tested HIV positive today, you want to say this individual has CD4 cell count below or higher than 200. If he has CD4 less than 200, he must receive those package of care, diagnostic package of care to eliminate, to exclude TB and to exclude cryptococcal meningitis. And of course, if they are not there, you have to give what you call prophylactic package. You must give prophylaxis for at least the TB, and you must also give the quota, must also prophylaxis. And if you have given the prophylaxis, you can start the antiretroviral therapy. If you have made the diagnosis of the disease, you have to wait until the time that we are sure you have cleared those organisms to a very large extent, so that if you initiate antiretroviral therapy, you are not going to have large infectious load or infection load that is going to precipitate high risk. So for TB, they say you must wait. You must wait for at least 2 weeks after you have commenced anti-TB therapy before you begin to think of giving antiretroviral therapy. For cryptococcal meningitis, yes, you have to wait for at least 4 weeks, sometimes 6 weeks, for you to treat cryptococcal meningitis before you begin to give this individual antiretroviral therapy. Otherwise, you are going to kill those individuals. And if somebody actually has TB of the brain or whatever, that may need a longer time for you to treat before you initiate antiretroviral therapy. But if you diagnose toxoplasmosis, you diagnose pneumocystis jirovecii pneumonia, you diagnose sepsis, those ones, you will start the treatment of these infections at the same time that you are starting the treatment for the ARV. The waiting time between starting ARV and starting for treatment of these other infections has not been really clearly outlined, but it is recommended that you could actually start the toxoplasmosis treatment, you could start pneumocystis jirovecii treatment, you could start antibiotic treatment while you are starting antiretroviral therapy. Don't try it with TB, don't try it with meningitis. And the last package of care is for individuals that have CD4 cell count less than 200. You give them what they call adherence package. You must follow them up every week for the next 4 weeks to be sure that they are alive and they are well. If you cannot bring them to the clinic like every week for you to them, you must. They call it adherence package of care. This is what we put together: diagnostic package, prophylaxis package, treatment initiation package, and what we call adherence package to manage an individual with HIV infection who have low CD4 cell count. You're welcome.
Thank you. Thank you very much, Professor Alani. And I will take that as your closing remarks as well, given that we've run low on time. Colleagues, keep those questions coming for as long as the platform remains open. We'll make them available to the presenters, and then we will make them form part of the package that will be shared out. Let me now hand it over to Eman or Kofo to just give your closing remarks in 1 minute. And if you've picked some interesting questions, you can build them in your closing remarks, just in 1 minute.
Yeah, I want to take this opportunity to thank the presenters and to thank ASLM for this platform. I think we've seen a lot of very interesting questions. We will take these questions and make sure we send a response to everyone. And looking forward to engaging everyone that participated at this meeting or webinar on a one-on-one basis. Thank you so much, everyone. Thank you. Bye.
Thank you, Kofo, there. And Eman, you want to add 30 seconds, your closing remarks?
No, just thank you for everyone's time. Thank you, Francis.
Great, thank you very much. And colleagues, again, like we always say, when we have an industry partner sharing with us technical information, and especially on products that are either QE or CE marked, we do not have any conflict of interest in any of this, and therefore we will always provide but only valid info. And presenting here does not constitute any endorsement for any product. There are many products out there that you can get to, but this is one of them. And I must also note that as ASLM, we're working with Akubio to scale up the utilization of this product in 11 countries, and our hope is that we will move this 11 or 24. My numbers are skipping, but we are hoping that we will get to more countries after the first phase of this. And with those, we are coming to the end, and please be rest assured that the slides will be made available through our different channels, and the questions will be responded to, and they will accompany the slides and the recordings herein. So from us, ASLM, do have the best of your afternoon, evening, or morning, depending on where you're joining us from. And a big thank you again to our presenters and the guys in the background who are helping us, the interpreters and the ICT team. Thank you again, and do have the best of your day ahead of you.